Hello class! We're going to discuss on 5 slides for today pertaining to the cervix and uterine corpus. So we have slide 14, that's carcinoma in situ of the cervix. We have slide 70, that is invasive squamous cell carcinoma. We have slide 75, that's endometrial carcinoma. Slide 208, that's leiomyoma. And slide 109, that's leiomyosarcoma. So let's start with slide 14. That's carcinoma in situ of the cervix. So before we are going to look into the malignant precursor or the precursor of the cervix, we start with the lining epithelium. Okay. So the lining epithelium of the ectocervix would be the stratified squamous epithelium, which is this one. Okay. And then if we're going to look at the lining epithelium, okay, let's try to look at this one. So the lining epithelium would show the presence of immature cells at the basal portion. Okay, how do you know that they are immature? They are identified with having darker nuclei, scanty cytoplasm. Okay, so they are the immature basal cells. As you go up, okay, to the epithelium, you notice that there's an increase in the amount of the cytoplasm. Okay, and then when you look at the stratum corneum, they appear to have a smaller nucleus, flattened nucleus, and then you have ample amounts of keratin. Sometimes there would be absence of the nuclei, which we would call them as enucleated squamous cells. So as you can see in this pattern, there's there's good polarity because you can see maturation and differentiation of the squamous cells. In this particular area, you would identify the presence of human papilloma virus associated change, and that is what we call as coilocytosis. You can see the perinuclear haloing, okay, of the cells with atypia of the nucleus. Okay, so with regards, the HPV-associated change would not be part of a premalignant lesion, okay, but it's part of HPV. Okay, so now we go into the premalignant lesion. There are 3 classifications that would be identified with cervical precursor. But before we go into that, let's look into the risk factor first. So the most significant risk factor for CINs or cervical intraepithelial neoplasia would be the human papilloma virus. So if there would be the presence of the high risk type, the 16 and 18, they're associated with the formation of premalignant lesions and even the invasive type. So HPV 16 and 18 would be different from the low risk type in a sense that they would have more virulence. They would have more activity for the E6 and E7 genes. So what are those genes? The E6 would bind with the P53 and make it inactivated. It also would increase the activity or would stimulate the activity of the telomerase, which is involved with immortality. E7 is associated with binding with the RB, and P21 and P27. So how do they infect the immature the squamous epithelium? Usually the HPV would infect the immature cells. So where are they located? They're located at the basal portion. Okay? But for HPV to infect them, there should be a break, okay, into the stratified squamous epithelium. Another source of infection would be if they would infect the metaplastic cells, which are more numerous on the surface. Okay? So those are the important aspects of the infection. So now we go into the classification. So how do we classify the pre-malignant precursors? So in the before the 1980s, usually the pathologists would classify the cervical intraepithelial neoplasia based on the presence of dysplasia. They call it as mild, moderate, and severe. So I think we're going to look at this particular area. Okay, so the mild dysplasia is classified based on the presence of atypical cells in the lower one-third. Okay? If you see atypical cells occupying the lower two-thirds, we call it as moderate dysplasia. If we see atypical cells occupying the upper portion, in essence, it occupies the entire thickness of the epithelium, you call it as severe dysplasia. Okay? Some would say that in order to classify it as carcinoma in situ, it should involve the uppermost layer. Okay? So that would be carcinoma in situ. Next, we have the classification of cervical intraepithelial neoplasia, or the CIN. So how do we fit it with the dysplasia? So CIN would be similar to the mild dysplasia, wherein we see atypical cells in the lower one-third. The CIN2 would be similar to moderate dysplasia, wherein we would see presence of atypical cells occupying up to the lower two-thirds. And CIN3 is similar to the severe dysplasia and also encompass carcinoma in situ. It means that there would be presence of atypical cells occupying the entire thickness. So right now, when we diagnose such cases, CIN3 would encompass carcinoma in situ and severe dysplasia. In the Robbins, they have a two-tier classification also, which is the low-grade and the high-grade squamous intraepithelial lesion. We would use low-grade squamous intraepithelial lesion and the HCl when we are diagnosing such cells in the pap smear. Okay, so LCl would correspond to the CIN1 and HCl would correspond to the CIN2 and 3. Okay, so if you're going to look at the slide, there would be this area. Okay, so what is this area? Okay, there would be the presence of a space, or there is, we're going to look at this portion. You can see that there's already a separation between this area, which seems to show presence of nest, and the basement membrane. So is this identified as stromal invasion and classify this as a cervical carcinoma? So as you can see in the lower portion, this particular area would be associated with this gland. Okay? So this is what we call as a glandular extension. This is another set. Okay? We can see that this gland would be associated with this nest. Okay? So this is still part of the gland, and this is what we call as glandular extension. So it's not yet a stromal invasion. So this is a glandular extension which we would see with the high-grade squamous intraepithelial lesion, or the CIN2 and 3. Okay? So with regards to, I'm going to talk about the staging of squamous cell carcinoma, because I think this is better discussed in this particular portion. So as you can see here, this is most probably a carcinoma in situ because of the surface involvement. The stage 0 for the staging of cervical cancer would correspond to this one, which is HSIL or CIN3 or carcinoma in situ. The moment that you have invasion into the lower portion, that is the time that you would call it as microinvasive carcinoma. But it has a limitation. So, stage 0 again is HSIL, CIN3, or carcinoma in situ. Stage 1A, it would be confined to the cervix with a limitation. So, stage 1A1, there would be invasion. Okay, but the invasion should not be more than 3 millimeters. It should not go more than 3 millimeters, and okay, that would be the depth, and the thickness, the width should not be more than 7 millimeters. Okay. If it goes more than 3 millimeters but not more than 5 millimeters, that's stage 1A2. Okay? So, 1A1 less than 3 millimeters, 1A2 less than 5 millimeters, and both of them would have a width of not more than 7 millimeters. If it goes more than 5 millimeters, that's the time that we call it as stage 1A, stage 1B. Okay? So 1A1 not more than 3 millimeters, 1A2 not more than 5 millimeters. If it's more than 5 millimeters, stage 1B. Okay. So, slide 70 is a continuation of what we have discussed in slide 14. And this is squamous cell carcinoma. Okay. So, this is the invasive type. Okay, because as you can see here, there's already frank malignancy. Okay. You can see the presence of nests going into the deeper layer. That's more than 5 millimeters. Okay? So, if this is confined to the cervix, we call it as stage 1. Okay? 1B. Okay? But if it goes into the uterus, it's stage 2. Okay? So, there are two types of squamous cell carcinoma. And we are going to look for this particular structure. What is this one? That is keratin pearl. Okay? So if you see the presence of keratin pearl, wherein you have the presence of whirling pattern, presence of keratin, and entrapped squamous cells, this is falling under the keratinizing type. If you do not see the presence of keratin pearl, but still you have the presence of some keratinization, you call it as the non-keratinizing type. Okay. So again, features, you have the presence of nests. Okay, presence of nests in the stroma. That's the time that you call it as invasive squamous cell carcinoma. Okay. So slide 75. This is endometrial carcinoma. So this is in the endometrium. With regards to the endometrial carcinoma, first we go into the two types of endometrial carcinoma. The type 1 is the so-called endometrioid type, which is associated with hyperplasia. It's associated with unopposed estrogen stimulation, and it's associated with obesity, diabetes, hypertension, and infertility. Okay? So, it's called endometrioid because it is similar to the glands of the endometrium. Okay? So, what are the mutations associated with it? We have the PTEN. We have the PIK3CA, which is associated with the PI3K signaling pathway. And only 50% of endometrioid type of endometrial carcinoma would have P53 mutation. So with regards to the differentiation, we have the well-differentiated or grade 1. We have the moderately differentiated, that's grade 2. and poorly differentiated, that's grade 3. Okay. So what is well differentiated? That's grade 1. If majority of the atypical cells are forming glands. Okay? So this is the well differentiated or grade 1. If you see atypical cells forming nests, which is not present here, okay? For example, like this one. Okay. Like for example, this one. They are forming nests. Then you call it as grade 2 if there's 50% or less of those nests. Okay, but if you have majority like 90%, 90% or more, some would say it's 95% or more. That's well differentiated, but it's very, 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 very small range. Okay, so if it's more than 50% composed of nests, then it is poorly differentiated. That's grade 3. Okay, so we look into the glands. Okay, so the glands are seen to be very close to each other with no intervening stroma in between them, like this one. The cells are known to have round nuclei, open chromatin or vesicular nuclei, and then conspicuous or prominent nucleolus. Okay, so this one would be a nucleolus. Okay, so open chromatin or vesicular nucleus. Okay. So they are seen infiltrating into the lower portion here. This would already be in the myometrium. If you see the presence of these smooth muscle fibers, okay, in the practical exam, it means that you are still in the endometrium, myometrium portion. And so this is an endometrioid adenocarcinoma of the endometrium. But if you do not see smooth muscle fibers like this one, then it is coming from the ovary. Okay, so that's one hint that you should remember. When you see the presence of these glands, you always look for the stroma. If it's smooth muscle, this is endometrial adenocarcinoma of the endometrium. Okay. So what about the other type? We have the type 2, which is composed of the serous carcinoma and the clear cell type. And this is the poorly differentiated type, and this would arise in the setting of atrophy. Okay, ang type 2 would be situated in a setting of atrophy. And in 90% of cases, P53 is the one that is mutated. Okay, so again, this one is type 1 because it's endometrioid type. Okay, it shows the presence of glands mimicking the endometrium. How do you differentiate this one from hyperplasia? In hyperplasia, you have the presence of these back-to-back glands, but they are separated by intervening stroma. Okay, but in this case, you have this gland and this gland, no intervening stroma in between. So this is regarded as malignant. Okay, so now we go to slide 208, and this is Leiomyoma. Sorry class, this is not a good slide, although we can still appreciate the presence of those muscle fibers. So please bear with me, sorry. Okay, so Leiomyoma is a benign neoplasm. Okay, it is composed of smooth muscle fibers, and it's associated with mutations towards HMG1C, HMGY, IY, and MED12. Okay, so it's sharply circumscribed. When we are going to look at it grossly, it's fairly circumscribed, well-rounded, very firm. Okay, And when we are going to see it in the uterus, it would be seen within the myometrium, we call it as intramural, or within the endometrial canal, which we call it as submucosal, or just pushing the endometrial canal, or it can be seen as a pedunculated mass. That's what we call a subserosal. Okay, intramural, submucosal, subserosal. So, histologically, we would see the whirling pattern. Okay, so whirling pattern composed of smooth muscle fibers seen in interlacing pattern. So, we have here the longitudinal, we have the longitudinal, and then we have the circular, longitudinal again, circular pattern. So, look at the curves, so the pointer. Okay, and they are composed of, let's try to look at, okay, this one. There, okay. So as you can see, they're composed of fibers that have elongated or long nuclei, bland nuclei at that. Okay, they do not exhibit nuclear atypia. Okay, which is very important to differentiate it from Leiomyosarcoma. So there are several variants for Leiomyoma. And for Leiomyomas, generally they have very low mitotic index. Okay, and that means you would have zero mitotic figure. Okay, the several variants that we have. Number one is cellular Leiomyoma. It means that there's an increase in the number of cells. Symplastic, which is symplastic, symplastic. It means that it's bizarre. You have the presence of large cells, the presence of cells having bizarre nuclear figure or bizarre nuclear features. Okay, and then we also have the mitotically active Leiomyoma. So you can see all of those are Leiomyomas. Okay, all of them have some features of malignancy. If you only have a few of them, like being cellular or being symplastic or bizarre looking or having mitotic figures, but you do not have all of them in one tumor, you still call them as Leiomyoma. But if you have all of them in one tumor, we call it as Leiomyosarcoma. Okay, now we go to slide 109. This is Leiomyosarcoma. Okay, so Leiomyosarcoma is already the malignant form of Leiomyoma. Okay, in this particular magnification, it's very difficult to identify if it's a Leiomyoma or Leiomyosarcoma. Okay, so the features would be similar. Okay, so you can have interlacing patterns of smooth muscle fibers. Okay, so you have here the circular. Okay, let's go to the higher power. Okay, you have here the circular, longitudinal, some circular, longitudinal pattern. Okay, but if you're going for the high power magnification, let's try to look for. If you look at the high power magnification, you see the cells to have, okay, high darker chromatin. Okay, they are enlarged. You have the presence of mitosis. Let's try to see other mitotic figures. There's another one. Okay, so you have presence of pleomorphism. So these are the features of Leiomyosarcoma. It is associated with MED12 mutation, there's a presence of nuclear atypia. Mitosis should be more than or equal to 10 per high power field. But in the Robbins, if you see the presence of marked nuclear atypia, 5 mitotic figures per 10 high power fields would be sufficient. Okay? And sometimes you would see necrosis, although I only saw hemorrhage in this case. Okay, but not mitosis. But not necrosis. Okay. If we have difficulty in classifying it, we call it as smooth muscle tumor of undetermined malignant potential. Okay, so I hope you learned something today. Stay safe, guys. It's lockdown. Okay, if you have any problems, uh, don't hesitate to text us through Telegram or through any form of communication. Okay, so don't worry, all of this will pass. Okay, we will see each other, okay, some other time. Okay, so good night and stay safe.